Grady Hospital, and I think the internet is slow. My residents confirmed that it is. It's only 2019. But okay, so we're starting to get into the point of this case. So we can see here that there is pneumatosis of the colon, pretty extensive, and some of the air was even looked like maybe even beyond the wall of the colon, like it was getting to like free pneumoperitoneum. And then, so I'm going to ask my resident here, do you have any thoughts about also this calcification down here in her pelvis?
Calcification of pelvis.
Do you know any differential for soft tissue calcifications? It looks like it's in the both the muscles and the subcutaneous tissues. And it's kind of sheet-like, which is one of it. She's a first year, so putting her on the spot.
Like someone had injections or like injection during one of them, but
yeah, so you can think about injections. Sometimes we can think about myositis ossificans, like if the patient is paraplegic, sometimes they'll get a lot of kind of trauma around their hip joints and they'll get a lot of myositis ossificans. So I was wondering if maybe they were bedridden and that's why they were getting like dystrophic calcifications here. But they're kind of like very linear and sheet-like. And if I was a musculoskeletal radiologist, I might have been able to diagnose this, but I'm not. And so this is dermatomyositis.
Oh,
yeah. And so they often get in their thighs, they often get calcifications in both the muscles. And basically it's, there's like necrosis that happens in the muscles from the inflammation. And then eventually it lays down calcification. So then can you potentially put together having dermatomyositis and then getting pneumatosis in your colon? No.
I don't know if steroids and then they had like really bad.
Exactly. So she's on steroids. And so this is a case of benign colonic pneumatosis. And that is seen with it can be frequently seen on patients on steroids, patients on various chemotherapies. So we called them, and actually this pneumatosis has been there on multiple prior scans. So we knew that it was benign, that this is just what this lady has, and she's been on steroids for a long time for her inflammatory skin condition. So often in our oncology clinic, we might see pneumatosis, and we'll call them frantically saying like, there's pneumatosis, and actually it's totally benign. So most of the time, 80% of the time, colonic pneumatosis is benign, not from ischemia. Okay. But if you see small bowel pneumatosis, you should always be really concerned about ischemia. Yeah, so this was kind of a cool case because, and then actually, apparently the steroids decrease something about the Peyer's patches and the lymph nodes. It actually causes some necrosis of the Peyer's patches and the lymph nodes. And that necrosis causes a little breakdown, and that's why the pneumatosis goes into the wall, because there's a little bit of breakdown of the mucosa from the steroids. But it's not from ischemia.
If you didn't have that history, I mean, is there any other way to know if it's benign?
Yeah, I mean, the patient should be really sick if it's ischemic, right? And then I would look carefully at the vessels. You could even if you have benign pneumatosis, you can get air in the vessels. So the air doesn't necessarily mean that that's benign or not. But if the vessels are completely open, like they are in this case, she was a young woman, she's asymptomatic. I mean, immediately you go to the chart and you kind of you don't want to miss the 20% that are going to be, more ischemic. But often they'll just be like, and then you go to the prior exams, you're like, oh, it's been there. Another one that we've seen quite a bit is actually if you on MRI, you can easily miss it, right? So you should look at the in and out of phase. If you start seeing some dark areas around there, look at the in and out of phase, but it still could be benign.